So good morning. My name is Munawar Shah. I'm one of the orthopedic surgeons. I have a passion of reverse shoulder replacements, and I will show you a technique, one of the techniques that's available to use, and hopefully we'll get some sort of understanding for it. So before I start my technique, we need to make sure that we make it as simple as possible for everybody to follow. And as Albert Einstein says, we have to it's a hard work to make a difficult problem simple, and I understand that shoulder replacement, especially reverse, is a difficult and complex procedure. Okay, to make it work, we must understand that it has to be dull and boring, simple, repeatable, predictable, and it's a numbers game. The more you do, the better you get at it, to make it dull and boring for everybody around you, so there are no challenges and nothing new, nothing difficult, and nothing out of the extraordinary for people to get worried or scared of. Okay, we need to plan. We need to make sure we have all the evidence and all the information available before we start doing what we do, because there is a lot of biomechanics involved here. Okay, my indications for doing a reverse shoulder is the appropriate age. If it's an irreparable cuff, there is a trauma with fractures of the tuberosity and a B2 and a C glenoid. These are some of the pictures from one of my patients here. There is a repairable cuff. This was a 79-year-old gentleman and had a nice reverse replacement. The second one was an 89-year-old lady who actually was left-handed, and we replaced the shoulder, but noticeably we have put the tuberosity where it should be, and I'll tell you why. The reason for that is it causes the deltoid to lateralize and therefore distalize, and therefore the function comes back to the tuberosity. Although we don't need a supraspinatus reverse in the trauma setting, we have to put the tuberosity back to allow the function to get where it should. Okay, and to achieve a range of motion, we need to have adequate soft tissue healing. And certain operations have contraindication, and reverse also has some contraindication, and the most common contraindication is infection if the deltoid is not working. However, there are relative contraindications which are all listed here. Okay, in my practice, I would x-ray the person and I will decide whether it needs surgery or not. If it does, I will make sure that I find the status of the cuff, and just find the status of the cuff, I will do an ultrasound, which I have a handheld one in my office, so therefore I have no problems there. The next thing I would like to do is, if I want to see if the cuff is repairable, irreparable, I'll do an MRI scan, do the Gottlieb classification. If it's irreparable, I know I can't do anything with this patient, especially if there is arthritis. If there is no arthritis, even if it's irreparable, we'll have to use some other method of getting it better. Gilly Walsh's classification on the glenoid was a revolution, and it changed the method of management of all shoulder arthritis and shoulder problems. Less anatomical are being done and more reversal are being done as time goes. Obviously, we need to know the Himada classification. We know if the cuff is torn or not. If it is the shoulder salvageable? And if it is not salvageable, then can we do a reverse replacement? Because in an absent cuff, that's the only option we have. In my technique, I do them prone with the arm freeze totally, so that I can fully extend and I can rotate without any obstruction to the shoulder. I now use tranexamic acid routinely, and my anesthetist does a brachial plexus block prior to surgery to have pain relief, and he leaves the catheter in. I have a delta pectoral approach, but my incision is slightly different. I try to go in the middle of both the coracoid and the AC joint, so that if I have to go medial or lateral for whatever reason, I have access to it. I sometimes will use a 1 in 1,000 adrenaline into the area of the scar, which actually delineates the tissue, and it's a lot easier to get into the planes. After I've given my incision, prepping and draping the patient, I will use a spinal retractor to retract the common conjoined tendon and the deltoid. This is the coracoid, and that's the conjoined tendon. Once I've done that, the first thing that comes into view is the three sisters, and I need to see them because when I do my cut of the subscap, I want to make sure that I cauterize them so they don't cause bleeding. I will then put some stay sutures and cut the subscap in external rotation. I will then release the subscap and release the glenohumeral joint, and with external rotation, the shoulder just pops itself out. I will always retain the biceps tendon with a stay suture to make sure that I reattach it after I had done my surgery, because if it's in there, it's an obstruction to function and causes pain. And if it's not there, they get Popeye sound dagger sensation from acute cutting it. So therefore, I incorporate it into my repair. Okay, this is a simple slide showing the biceps tendon being cut and stay sutures put in. I will then do what is called a circumcision of the glenoid. I use a bunny ears retractor to go under the glenoid inferior margin and clean up the tissues all around. So I need to make it look devoid of any tissue around, so that it doesn't interfere in my procedure. At that stage, I will ask my anaesthetist to tilt the table 30 degrees away from me in the line of the scapula. Therefore, when I put a wire parallel to it, it is going in the direction I want it to go. Trauma is a different scenario altogether. I don't need the same approach. We need what is called a trapdoor opening approach. What I do is I take the two tuberosities, put some stay sutures, and then use an osteotome if I need to split it. Biceps being my guide. I will then take the greater tuberosity and lesser tuberosity with the tendinous part with stay sutures to allow me to reattach it when I need to. I will open it. I will take the head out and make some drill holes into the humerus for future reference. Once I've done that, the glenoid is right in front of me. This is what the sutures will look like when I'm closing, and that's what it looks like after I've closed it. I will put bone graft in there to allow it to heal onto the implant. Okay, this is a cutting jig in the new model of the implant or the system I use, which is the SMR reverse, and it causes some grievance to me because of fiddleability, as I call it. So as my implant has already got a 135 build into the body, I'm not, I mean, I'd like to have a good cut, but I'm not fussed about it. What I do, like I said before, is mark the humerus. I will put the 12 o'clock, 9 o'clock, 6 o'clock, and 3 o'clock around it. I will connect the dots, and then I will cut in that line at a 135 angle to make sure that I have a good humeral cut. Once I've done that, I will mark the center of the glenoid. Once I've marked the center of the glenoid, I will put my drill into it to pass to both codices of the glenoid into the neck. I will then use my reamer of the glenoid to see if I'm in the center. Once I've done that and decorticated it, I will use my glenoid peg reamer. I have a choice of small, standard, and small. I use the small because it's got a longer peg in it and therefore allows good stability long term. I will then take the real implant. I don't do the trials here. I will put the real implant and put it in. I will two drill holes into it. The screws are always 25, so I will have 25 screws inserted in these. The screw is 6.5 and the drill is 3.2, so I sometimes use the drill to make the hole a bit bigger. And I will also put the screws sequentially halfway rather than all the way completely. I will then use a 40 Glenn sphere, put it in, put the screws in, and that's my scapular part done. I will then ream the humerus to take a body size. Once I've done that, I put the head adapter onto it. And once I put the head adapter into it, I will put it together into the humerus. I use 20 degrees of retroversion, and that's dialed into it before my final positions. Once that's done, I will take this out, and I will use one of the vicious implant that I call the body maker. It will make the body, and this needs to be buried into the bone. It's because it's an inlay system. Once I've done that, I will take the hole out and my humerus is prepared. In trauma situations, I will prepare the humerus, but I will have to leave the implant proud for the tuberosities to come back in. And the general feeling is at the top, from the top of the pec major, you should be about 5 to 6 centimeters high. That's the right thing. And the easy way to do it is if you put your implant in and bring a tuberosity in, it just fits. Saying that, it is difficult in trauma, but you have to get it right. I will then put the real implant in. There is a cheat code here. Is I will put a standard body all the time. If it's a trauma, I'll put a small body, and I never use the fin body implant for the trauma. I also know that the implant sizes come in straight figures such as 13, 14, 15, 16. So if my 15 is tight and 14 is loose, I will take the bone from the humeral head and put it in there to make it into a 14 and a half. And that works all the time, and it's amazing how stable it gets by just putting some bone graft into it. I will then lock the body into the humerus. And this is the first thing I do is for trialing. My trials are small, medium, and large, and I will look at stability, and I will look at how easy it is to dislocate. Once I'm happy with that, I will close the whole system. There is a small body, a trauma body, and a standard body. There are platforms or augments, which is 9 millimeters, and we have a 3, 6, and 9 millimeter spacer insert. This is what the device looks like once we've put a platform onto it, i.e. an inserter or a spacer. So in my practice, I always, like I said, use a small base plate, 225 screws, 40 Glenn sphere, a standard body for A and a short for trauma. I always do bicep tenodesis and repair the subscap if I can. Okay, this is some of the patients I've done recently, and it's the numbers game, as we all know. So everybody learns in the job, and for me, the first dislocation was terrible, and I realized it was my mechanical fault rather than the implant's fault. And if you look at the picture from before, it's 2 medialized, and if you put an implant normally, it will dislocate. So what I learned was axioma, which is a longer peg, which allows more stability and lateralizes the center of rotation where it should be, i.e. put it where it should be. So in my patients who've got a good humerus, humeral head, it's a primary event. There is no glenoid, or it is lateralized. The center of rotation from the coracoid and the acromion point is medialized. I will put it back where it should be. I will put the base plate onto the humeral head, take it out with a coring implant with bone grafts, and put screws in there to hold it, and that's lateralized. These are pictures. Post-op, you can see that I have lateralized it. The peg is holding it, and hopefully this will be stable. Similarly, if I have no head and no glenoid, and I need to lateralize it, I can take the bone graft from the ileum, put the base plate on it, and take it out, core it, and I have a nice little bone graft. Okay, this is what the X-ray looks like from the pelvis after I've done surgery to it, and this is what the post-op X-ray looks like. So one cannot do the same thing all the time because it gets very boring. For my personal development, I started to take difficult and complex cases. Initially, it was primary complex, and then started doing revisions. I have a system which allows me to in the primary complex one, to map after a CT scan what implant I need and how much rotation I will get. And that's good, and it helps me to understand the biomechanics, or it did help me to understand the biomechanics. Okay. And after that, I went into what is called a patient-specific implants, and implants were made for me to allow better understanding. This is the case of mine. It was a young girl. She was 25, and she had shoulder replacement and anatomical. She was rheumatoid, and 14 years down the line, she wore a glenoid off completely. So I had taken the initial implants out because it was a different system, and I put a cement spacer into it, and I CT scanned it. And after I did a scan on it, it told me that there was not much left of the glenoid, and it would be very difficult to put a standard base plate. Even an axioma would be difficult here. So my engineers made me a patient-specific implant, which is called Promade, and it was a coracoid-based implant. I was told after discussing with the engineer that where my center of rotation will be, how far it needs to be lateralized and distalized, and jigs were made for me to make sure that this is what the implant would look like when I put it in, and this is the 3D reconstruction of it. These are jigs where initially I put in to put a wire in. After I put the wire in, I will make a peg hole, and then hopefully I will put the real implant in. And this is the implants after I've used them, and this is during the operation. This is what it looked like on the day post-op, and the patient since then is a year down the line and has gone back doing a hairdressing job. She can't abduct beyond 100 degrees, but the pain's gone, and this is what we have achieved with this particular implant. Finally, I just want to share another implant. This was done somewhere else. Again, this was medialized. The surgeon did not realize it, and the implant dislocated post-op. Once it dislocated, the surgeon thought that maybe it was the option. The option was bad and wanted to do an extended articulating surface arthroplasty. Even that dislocated, so I took it out and put a cement spacer, which is a nice fancy one, and then I sent it to my engineers, who showed me that it was just barely in, it was not totally in. They told me that this implant would be coracoid and acromion based. They gave me a center of rotation, how far it needs to be lateralized, and this lies in where it needs to go into the humerus. They sent me some patient-specific jigs to allow me to put the K-wire in first, and then the peg, and then the implant with the trial one, and then the real thing. This is the end result of it. The patient invariably has now a shoulder that is not dislocated, no pain, function is returning to normal. She's only 6 months post-op. So I will share you future as we get on. I hope this helps. This is my view of my way of how to do a reverse polarity shoulder.